let's talk about actually the measuring of blood pressures. I'm old. When I trained, I actually bought, we all had our little mercury manometers, and remember the little column of mercury that you're not allowed to have anymore in an ER because, I don't know, you may have a momentary suicidal ideation moment and go gnaw on it and then, chew up some of that mercury. I don't know. It was actually fun when it broke. You could chase it around the floor. It was actually kind of fun. We can't have those anymore. And what's actually kind of cool is that you don't have to teach people about carot cough sounds and, pumping the pressure cuff up till the pressure, till the pulses are gone and all those things we used to have to treat. These days we use electronic or aneroid type of manometers, and they aren't necessarily any better. In fact, they may actually have some inherent problems. Abstract 26 basically just looks at the fact that we do all these automated blood pressures these days, and we wrap the cuff around and we push a button, but sometimes these things actually be erroneous when compared to true mercury manometry, which was the gold standard forever. Abstract 26 is one of a couple papers out there that look at that comparison, mercury versus either aneroid or electronic blood pressures, and find that they tend to overestimate systolic and underestimate diastolic blood pressures, but by amounts that are relatively clinically insignificant. So yes, they can be off a little, but it tends to be clinically insignificant with the exception of the hypotensive patient. It starts to fall apart at a systolic of about 50 to 60. And I think if you think about your clinical experience, that fits, right? Somebody who starts to get down, and to be perfectly honest with you, a systolic of 50 or 60, they need you. They need resuscitation. I don't care if it's 42 or 54. They need you. So I honestly don't think that the number makes that much difference, but do know that at the low end, all of those aneroids and electronic things tend to fall off. And if you're somebody who's still checking things like ABIs and somebody who has really bad pressures, you're trying to do it with blood pressures, be careful with that, actually. If they have really bad peripheral vascular disease and you're trying to measure something like an ABI, you may need to actually have a Doppler and a true mercury manometer to get a true good measurement. This is kind of one little quirky thing. What's the most common mistake we make in checking blood pressures? Cuff size. Flat out, hands down, no question, cuff size. Can you tell me what an appropriate cuff size is supposed to be?
Look at the range on the cuff.
Look at the range on the cuff. Go cheat. The reality is there are formulas for this. There are things that you're supposed to use. And what's if you think about it, I walked through my ER the other day and kind of just looked at patient to patient to patient. And I went from the bedside of an 86-pound 90-year-old to the bedside of a 690-pound patient. If you use the wrong cuff on either of those two, you're going to get the wrong blood pressure. What if it's too small? What if I take that 690-pounder and we couldn't actually get a regular cuff, even although it was long enough to even go around. But if it had been, what if I used too small of a cuff? What am I going to get? Too high of a blood pressure. What if I use too big of a cuff? Too low of a blood pressure. So my teeny little old lady, who was this big around, they were using a regular cuff on her, but they had to wrap it around like 3 times to get it to actually go around her arm. That may falsely read her blood pressure as low. So be careful with this. This is really common. The most common errors are the wrong cuff size. I'll give you some information, but honestly, if you want to check the numbers, that's probably the best way to do it. And good blood pressure cuffs will have a range. When you wrap it around, it should say, between this mark and this mark is where it should actually overlap. And if it doesn't, that's the wrong size cuff. But basically, the bladder itself, the length of the bladder along the length of the cuff should be 80 to 120% the width of the patient's arm, or the diameter of the patient's arm. So it should be 80 to 20%. The bladder width should be 40% the circumference. I remember the old days. We used to pick them up and we'd hold them up, we'd turn them longwise and we'd kind of try to wrap it around the patient's arm, then we'd turn them lengthwise and we'd wrap it to see if it actually fit. Don't bother. Just make sure that the marks on those cuffs actually fit. The length to proportion should be about 2 to 1. The reason it is important is it does cause abnormal blood pressures. Number 20, abstract number 20 looks at 470 unselected patients. And this is actually, I like this study. They used automated blood pressure cuffs, because that's what we all do. They threw out there, what they used is standard size cuffs, large cuffs, and thigh size cuffs. Our 690-pounder the other day needed a thigh size cuff. So they had those 3 cuffs available. They also divided patients into 2 groups, BMIs greater than 34 or less than 34. Now at Harbor we have what we call the Harbor scale. There's Harbor small, medium, and large. The 690-pounder actually falls into the Harbor extra large. I gave a lecture in Ohio a while back where they had Ohio units. Any of you guys from Ohio? I was in a residency program where they measured people in Ohio units, 1 to 5 Ohio units. There were Iowa units. I've heard these various things. The bottom line is BMI can make a difference. And what did they find here? They found that If a standard blood pressure cuff was used on a patient that's too big, it caused a significantly higher reading, inappropriately hypertensive reading. If they went to the appropriate sized cuff, let's go to a large cuff in somebody who really needs it, what had originally been hypertension went down to actually borderline hypertension in about 33% of them, and went down to totally normal in the other 62%. This is important. So the cuff size is important. And abstract number 25 basically said they took a bunch of nurses who took nurses and medical students who took 200 blood pressure readings, and what they did is they just turned them loose to the patients and a bunch of different cuffs and let them just use what they were going to use. What they found overall is that under cuffings were in about 84% of the errors made. Again, too small of a cuff. So the key is just to make sure, if you have somebody's blood pressure is really high, make sure the cuff is the right size. And if it's low, just go double check and make sure it's not like my little lady who had it wrapped around 6 times. It actually may be the wrong size there as well. So cuff size is the biggest problem. Under cuffings most commonly. The other thing is, if I were to check your blood pressure lying on a gurney comfortably with your arm at the level of your heart and compare it to your blood pressure with your arm dangling, I'm going to get up to 10 millimeters of increased pressure dangling compared to the level of your heart. So that can make a difference as well. That's at the abstract number 22 and 23. Look at this. You can get a blood pressure elevation that's not appropriate of as high as 10 millimeters of mercury. Now let me tell you what the JNC7 says about taking blood pressures, and apply this to your clinical situation. The patient should be sitting comfortably for 5 minutes prior to the blood pressure. Should all chant a little bit. Avoid caffeine, exercise, and smoking for 30 minutes. Good luck. They're all outside smoking all the time. The arm should be supported and extended at the level of the heart, and you should take 2 measurements and record the average. This is just not practical for what we do. What we can do practically, though, is get the right size cuff and have the arm at the level of the heart. So don't have it dangling down there, have the arm at the level of the heart. You can at least do those 2 things as far as taking blood pressures in our patients. So there's some things in JNC7 we can do and some that just aren't particularly practical. So those are our mistakes that we make. What about white coat hypertension? This is abstract 28. Can that happen? You all know there's white coat crying in kids, right? All you have to do is drift anywhere near a child wearing a white coat and they completely scream bloody murder. Do people get elevated blood pressures as you, as the physician, walk in the room? Can that happen? Abstract 28 is one of several studies that have looked at this. I kind of like the design on this. This was done actually in patients that were in the hospital with art lines. So they actually monitored art lines and blood pressures in patients, checked them kind of before, during, and after. And they compared it to when the doctor walked in the room and the doctor checked the blood pressure several times during the visit. The blood pressure did go up when you walked into the room. But by the time you'd been around and shuffling around and doing your thing for 10 minutes, actually, in this study, the blood pressure came back down to what it had been at its baseline. So that if you were to walk in and take the blood pressure on every single person, the minute you walked in the door to talk to them, their blood pressure may go up. But by the time your visit is done, it's going to come down. And most of the time, we don't check the blood pressures anyway. It's done way before we ever see them. So white coat hypertension can exist. It's clinically insignificant for the most part. Yeah?
What about blood pressures that are higher by 20 points in the office, even after they've been in the office for half an hour, compared to their home blood pressure readings? And they check their home blood pressure cuff against the office cuff.
I can't give you any recommendation on that specifically. The question here is, what if every time they come to my office, it's 20 points higher than they have recorded in their little diary that I have them keep at home? I can't tell you what to do with those, honestly. It may very well be white coat hypertension, and I think the trend is more important than the specific number that day, but I can't give you any, at least evidence-based guidelines. What do you guys do with that, those of you who are office-based? What do you do? Yeah, she mentioned that. Yeah, check the monitor to make sure the blood pressure is okay. I like the Walmart, checks. I stick my arm in that round thing, and it checks my blood pressure, and it's always fine at Walmart. So yeah. What about this? The nurse comes up to you and says, "Doctor, I just came back from my recertification, my CME course, and I went and checked the blood pressures in the right and the left arm of that patient over there with the ankle sprain, and their systolic is 20 points different, their right arm compared to their left arm. I think it's a dissection." Is it?
If it's continuous, it's probably subclavian stenosis.
Well, actually, this is interesting. We're all taught. I was taught 20 millimeters of mercury difference in systolic, 10 millimeters of mercury difference diastolic, highly suggestive of something blocking flow in the right arm compared to the left arm. That's what I was taught. And that something is often felt to be dissection. You need to worry about dissection. What I love about these studies is they went, you know what? let's go to that emergency medicine abstracts course, and let's just walk around that room and check everybody's right and left blood pressures and see how they are. See how you guys are. What is the sort of across the board difference in just walk and talk and people have ankle sprains or have just been skiing? What's the difference in your blood pressures? What they found in the 4 abstracts that are in this section, or 3 abstracts that are in this section, and a total of about 700 patients, almost 800 patients, is that you can have a systolic difference of 10 millimeters of mercury in as high as 40% of patients, 20 millimeters of mercury in as high as 4% of patients. And diastolic is about the same, 4 to 10% of patients who are fine have a systolic or diastolic difference that would raise an eyebrow. This is like every other thing out there. You have to put it in clinical context. If the person has an ankle sprain, they're fine, they're not dissecting. If they've got some funky, weird back pain, then worry. If they've got new paraplegia out of nowhere, worry. If they're hemiparetic, worry. They may have actually dissected, but you have to put it in a clinical context. So that sort of differential blood pressure sign is not it's not pathognomonic for having the diagnosis. You have to put it in clinical context. It's sort of like, and that's not, their articles aren't in this section, orthostatic blood pressure changes. Okay, I can test all of you right now, lie you down, sit you up, stand you up, and probably about, well, the data says anywhere between 8 and 15% of patients will have number changes consistent with orthostatic hypotension, okay, orthostatic blood pressure changes or heart rate changes. The reality is, unless you're symptomatic, it's not particularly helpful. Unless there's some reason that I'm worried that you've lost volume somehow, it's not particularly helpful. So this is similar, it falls into that category. So be careful with those. It doesn't necessarily mean anything, put it in the clinical context. So that's the part 1 that we kind of wrap up. Let's do part 2. So you have a patient that's sitting in the ER with a blood pressure of 190 over 110. Now, back in the day when I trained 25 years ago in internal medicine, we had a panoply of tests we would order. It was just a knee-jerk, anybody who was even as low as 160 over 90. They were in the ER, we ordered a series of tests. We ordered a complete metabolic panel, a CBC, an EKG, a UA, and a chest x-ray. Do y'all do that anymore? God, I hope you don't do it anymore. The reality is asymptomatic hypertensive patients up to a blood pressure of 220 over 120, I'll talk about those in a sec, don't need any tests from you. Let me ask you a question. What does the EKG show in somebody with asymptomatic hypertension? You've all seen them. What does it show? LVH. Do I care? Not in the slightest. Not in the slightest. What does the chest x-ray show? Usually nothing. Maybe a little bit of borderline cardiomegaly. Usually nothing. Again, I don't care. If they don't have symptoms of chest pain and they don't have symptoms of shortness of breath, I don't care. I don't want my cardiologists and radiologists driving those fancy cars any more than I have to help them to get those things. So I don't care about those. There are a couple of tests that are a little harder to blow off. The urinalysis and complete the CBC, I don't care. I mean, the CBCs, these days, I hate the CBC. The older I get and the more I practice, the more I hate the CBC. White counts are only a surgeon's excuse not to do the surgery or to do the surgery or to do something crazy. I can get a hemoglobin rapidly if I need it. If I'm worried about leukemia, I'll send a CBC. Okay, I find these CBCs not particularly useful. But the complete metabolic panel in UA may have some validity. Abstract 32 looks at a bunch of patients, actually 109, that had systolics greater than 180 and diastolics greater than 110. All of them had all those tests sent. Now, if you wanted to spin this paper, what they found is an unanticipated abnormality was found half the time. And if you wanted to stop there, you could say, oh, I need to get all those tests. Bless them, they didn't. They actually went on and they said, what is that? Whoa, whoa, whoa. I found a creatinine of 1.1. I didn't expect it to be up a little. I don't care. I found a little bit of cardiomegaly. Yeah, whatever. I found an EKG showed LVH. Whatever. They actually found that there were only about 6% that had any clinically meaningful significance at all. And what it usually led to was calling the cardiologist and saying, can I get him in your office tomorrow? They got some LVH. Do you mind seeing this one a little sooner than if I just refer to the primary care provider? Very few of them it meant anything as far as any acute intervention or admission. So in general, and again, this is asymptomatic, not sort of off-scale blood pressure patients. Don't send anything. Okay, all you're gonna do is worry yourself. The group that falls out, and the literature is really hard to pin down on these, are the people with systolics greater than 220 and diastolics greater than 120. That's the group that, if you go back and you look at the original VA study on hypertension, which is now 30 plus years old, that is the group that was more likely within 1 month to have something bad happen. Okay, 1 month. Should you be screening those asymptomatic patients in the ER? That's kind of up to you. But if you do, what I recommend you use are the complete metabolic panel and the UA. Because what I really recommend you do is look in their eyeballs. Your kidneys and your eyes go in parallel when it comes to hypertension. If you start to have flame hemorrhages in the back of your eyeballs, odds are you're knocking off your kidneys. So those tend to go in parallel. So look in the eyeballs and take a look for those AV nicking and copper wiring and all that stuff you learned about in med school. And that may be an indicator of kidney function issues as well. That's the only case, I think, really where doing tests acutely in the ER is useful. It's tempting. And I'll tell you, I can't tell you how many times, I'm sure you're all in the same boat. We have our clinics that will call and say, Mrs. Smith is here in my office, in my clinic, and her blood pressure is 190 over 110. I'm going to send her to the ER so you can check her out. Is she having any symptoms? Is she hemiplegic? Is she short of breath? Is she having chest pain? No. Well, why? Why send her here? I'm not going to do anything for her any differently than what you would do there. So don't fall into the pitfall of they're in the ER, they must need tests. They don't. The other pitfall you don't want to do is somebody comes up and the nurse says the blood pressure is 200 over 100. It just looks so bad on the chart to send somebody home with 200 or 100. Let's buff the chart. Let's treat that. Let's treat that number. The patient's not symptomatic, but let's treat that number. Let's buff the chart. Resist that as well. Okay, resist that temptation as well. A couple papers in here look at this. First of all, what we'd like to know first is if we decide we want to buff the chart and give a drug, does it work? I mean, if I'm going to do it, I'd like to do something that might work. So abstracts 33 and 34 both say yes. Giving a drug in the ER will work, giving a pill of whatever you choose. Abstract number 33, which is a paper that was from 1983, used atenolol. Abstract number 34, which is a paper from 1989, used 1989 type drugs, clonidine and chlorthalidone. What they found in both of these studies, well, they found two things that I think are important. One is you can get the blood pressure lowered with a pill. But to really get it lowered significantly takes, in any sort of measurable, takes about 12 hours. And at 24 hours, there's no difference in giving a pill in the ER and sending him home on something than just sending him home on something. Have him start a medicine at home. So if you're going to give a medicine for an asymptomatic hypertensive patient, just give them a script and send them on their way. Don't wait to buff the chart. You'll be waiting a long time. And there is some potential downside to that. That we actually do this quite a bit. Abstract number 35 says at least in 1999 we did it a lot. But there is a potential downside. Abstract 36's title says it all. Stroke precipitated by moderate blood pressure reduction. Now this is a paper, it's basically a case report of 6 cases of patients who had either worsening neurologic function or true stroke from being given antihypertensive agents in the emergency department to bring down their blood pressures. What's interesting is none of the patients got hypotensive. You would think the patients that would go stroke out are the ones that oops, I overshot. I shouldn't have given that much med, or I gave the wrong kind of med. It wasn't that. Actually, these are people who live with autoregulation in their brain that says, hit me. I'm used to you hit me with this high blood pressure, and all you had to do was lower it enough. Didn't even have to go hypotensive to get these patients to have neurologic dysfunction. So be careful with this. These are people that had blood pressures reduced usually with oral nifedipine. And that was something a lot of us used for a long time, was oral nifedipine. Don't do it. You don't need to do it. Abstracts 37, 38, and 39 are worth a read. And I recommend when you're hanging around upstairs, tonight, bored, give it a read because they all three, one's a review, one's an editorial, and one's a commentary. But they all give very cogent arguments against acutely treating blood pressures in the ER and basically getting people onto the thought process of this is a treatment for life deal. Okay, referral, treatment for life deal. Very, very good cogent arguments against giving these kinds of treatments in the ER. Now, what does ACEP say? We'll have to have a moment and genuflect. And what do the grand poobahs out there say in their clinical policy? Well, this one's pretty reasonable. They say basically, this is a thing that was published in 2006, one of those clinical policy guideline things they do. They said patients who have persistently elevated blood pressures, 140 over 90, so the ER, you get the first one's up, second one's up, it's 140 over 90 or higher. They should be referred for follow-up. Excellent. What if you only have one blood pressure? It got checked at triage for that ankle sprain, and while you're getting the dictation to send them on your way, it's like, oh, ooh, shoot, I forgot. Those people should also probably be referred. You're better off rechecking, but if you can't, they should probably be referred. Do not rapidly lower the blood pressure. It can be harmful. If you don't need to initiate treatment if you're sending them for follow-up and they have access to it. And this is where My practice differs from a lot of yours. The optimal way to manage somebody who has elevated blood pressure is a really good primary care doc who talks to them about their disease and the options that they have and chooses the appropriate agents for them. I don't have access to this where I work. Our clinic system has been decimated. People get into their doctor within a 6-month window when I refer them from our emergency department. So I frequently will put somebody on a med in the ED. But it's usually the cheapo, easy, and I'll talk about the guidelines later, but usually it's a thiazide. Stick them on a thiazide and send them on their way. It isn't some big fancy schmancy expensive deal. It's usually a thiazide. But in some instances, depending, and you'll just have to see your clinical practice, whether it was something you would add into your armamentarium, but we do in ours. And don't buff the chart. If you do start somebody on a med in the ED, don't wait till their blood pressure is normal. It won't get there. And if you're antsy to get them out, you'll lower them too fast. So don't buff the chart. Basically, it said don't expect the blood pressure to be lowered during their ED visit. The last little bit in here is the JNC7 guidelines. And I think the most important thing to know about the JNC7 guidelines for all of us, so we're working in the ER, the patient's blood pressure is 160/90, it's really sitting there at 160/90. When you refer them, what you're not referring them for is to go get a pill. What you're referring them for is the sequential approach to the management of somebody whose blood pressure is elevated. They need a workup. Okay, there's certain things that are done in the office on that. But what they need more than anything is lifestyle changes. The vast majority of hypertensives, if they lose 10% of their body weight, will no longer be hypertensive. 10%, that's all it takes. It doesn't take a whole lot, even in people who are obese. Sometimes just as much as 10% will bring their blood pressure down to normal. So the first intervention done is lifestyle modifications. Weight reduction, watch their salt intake, increase their sort of exercise, watch their alcohol consumption, the basics that are just healthy living for anybody. If that doesn't work, or if the patients are recalcitrant and say, I'm still drinking and I'm going to sit there and channel surf, and that's it, buddy. I'm going to eat my pork rinds and that's it. You're stuck with it. Then those people can get put on drugs. And there's a whole approach to these. And there's some specific called compelling indications like diabetes, certain age, heart disease, et cetera, where some med may be better than others. In general, thiazides are a great first agent. Cheap, effective. If you need to add a second agent, you have a litany of things to choose from. I'll let you read it because it's really more applicable to your practice. It's boring to have somebody read this to you. But I think overall, just know that blood pressure is common. Our job really is to refer. Okay, get somebody referred. If you are somebody who's accepting the referral, your job is to lifestyle intervene if they're really hypertensive. And drugs are sort of what we do at the end, and we start with the cheap stuff. Any questions on hypertension? Yeah.
Yeah, so I just kind of wonder how to do this then. About that number. One British study where it was their mean were 230/150, and they gave them 100 atenolol.
Yeah.
Sent them home, I gather.
Uh-huh.
But I think that's higher than the last couple of hypertensive hemorrhage people I've seen. And so then it seems like there'd be some level of asymptomatic hypertension that you would want to lower more.
So your question is, that study actually, they were extraordinarily high in that group. They were all over 220/120 in that group. Some were as high as 250. We used to, in the old days, any of us that are gray, we used to call those patent pending over palp. Because if you pumped the manometer all the way up at the top of the manometer, it said patent pending. So those were all patent pending over palp patients. They were the ones that were just off scale hypertensive.
So there's some level of asymptomatic hypertension you think we should urgently lower?
I can't give you an evidence-based deal on this, and this ends up being a comfort zone. Please don't let your comfort zone be lower than 220 systolic and 120 diastolic. But it does get to a point where even, I think, the purist gets a little antsy. If you lower it, though, probably you're not going to get them significantly lower in the ER. The key, I think, is to start them on something. If they're asymptomatic, again, this is asymptomatic, and I usually do check a UA and a Chem7 in those patients. If their creatinine's up a little, or they're spilling red cells, or tons of protein, I may actually have that patient stay in-house for a couple of days to make sure their blood pressure gets controlled on a not over 2 or 3 weeks when they make it to the office basis, but while they're in the hospital, they get into a decent range. That's somebody that is one of the few cases that might qualify as a hypertensive urgency, which is this nebulous, nobody knows what it really is group. So can I give you a number? No, but it is one of those things where if you sit around with a group of people and it gets higher and higher, I think it's reasonable at a certain point to say, that's it. I'm not comfortable. 250, 230, what I'm not, and I think that's fine. But don't expect to normalize them. You won't. Yeah.
Can you say something about the definition of symptomatic?
Ah.
I'm weak and dizzy. I had an argument. My blood pressure's really high.
No.
If you get rid of the symptoms, and
the symptoms are real symptoms, not just I have a headache with this. Now again, this is what is the headache? Is it just a little occipital kind of throbbing, or the thunderclap? what is the headache? Or I'm feeling a little weak, is make sure it's not a stroke kind of weak. Or I just get really anxious and I'm feeling short of breath. Listen. If there's evidence of pulmonary edema or congestive heart failure, listen. And the hardest one for me is I'm anxious, I had a fight with my boyfriend, whatever, I had a fight with my husband, and I'm feeling my chest kind of tight. That's the one I find the hardest. And that's when I go ahead and do the full ACS flog. It's like, okay, stress does it. Now we're shifting over out of just their blood pressure's up category, and I'm going to worry about ACS in you. Symptoms need to be real symptoms, not just the vague, I'm feeling a little weird, a little off. Not that. They need to be more real symptoms.
My left arm, right leg went numb.
I love that. The asynchronous neuro exam, the left arm, right leg, I'm tingling all over one side and my pinky's a little sore. Yeah, those, I don't think those count. Over here there was a hand? Yeah.
Has anybody ever looked in the elderly at the effect of atherosclerosis and how much force it can just compress the vessel because it's hard?
Yes, indeedy. They're actually not in here. And nobody's doing that data anymore because we're not doing mercury manometers anymore. And that's where the whole carrot cough sound and the pumping up the cuff till the pulse goes away was real and was important. So the old way we used to do it, it was important because you had to feel the pulse while you were pumping up that cuff because of that. Older people, you've got to go way high to get that vessel actually cranked down. And one of the debates back then was, is it false hypertension? Is that isolated systolic hypertension because of atherosclerosis real or not? Yes, it's real. Yes, it's real. And I'm not sure, no one to my knowledge has looked at that issue on these automatic cuffs, on these electronic cuffs and these aneroid cuffs. I've never seen anybody look at that issue specifically. Now, if you've ever had your blood pressure taken for one of those things, those buggers go flipping high. The patients are like, you can tell who's cycled on 2 minutes, 5 minutes, and 10 minutes in the ER by the shrieks that come from around the ER. It's like, it's like, they go pretty high. But I'm not sure that it's been proven that they go high enough in everybody. It's a really good question. Any other hands up anywhere? I saw somebody over there. All right, we're going to do the panel.